My name is Wiona Moras, currently working as an assistant professor in the Department of Pharmacy Practice. Today I'll be explaining about the module called as GERD, that is nothing but Gastroesophageal Reflux Disease. So in this module we'll be mainly focusing about the introduction, etiology, symptoms, treatment, diagnosis and pathophysiology. So in this we have a specific learning outcome, that is the student must be able to understand the definition, etiology, clinical presentation of GERD followed by pathophysiology and diagnostic test and management of GERD. So coming to the introduction, GERD, that is, it stands for Gastroesophageal Reflux Disease. It is nothing but it is a chronic disease that occurs when stomach acid, that is HCl or bile flows into the food pipe and irritates the lining. We have etiology, that is defective lower esophageal sphincter pressure, that is called as LES. It is nothing but it is a muscular ring which is present at the junction of esophagus and stomach. So the main role of this LES, it will prevent the backflow of stomach content. Next we have anatomic factors, that is nothing but these are the structural abnormalities, that is change in chromosomes. For example, Down syndrome or Turner syndrome, that might affect the LES function or it might promote the reflux. Next is increased intra-abdominal pressure, that is seen in mainly with the patients with obese, pregnancy and chronic cough. Next we have gastric emptying. It is nothing but it is a process where the food or the liquid, it will move from the stomach into the small intestine. So the average duration of gastric emptying is between 2 to 4 hours. We have composition and volume of gastric acid as well as pepsin. So this pepsin is nothing but it is a digestive enzyme which will break down protein into peptides. We have bile acid as well as pancreatic enzymes, that is nothing but trypsin. Next we have food and medication that might worsen the condition of GERD. Food such as fatty meal, the medication uses anticholinergic. Next we have carminative, that is barbiturates, for example phenobarbital. Chocolate we have caffeine content. For coffee, cola and tea we have dihydropyridine calcium channel blockers. For garlic we have dopamine. For onions we have estrogen. For chili peppers we have ethanol. Next, coming to the symptoms. Symptoms includes heartburn, hypersalivation, that is called as excess of watery mouth, dysphagia, that is nothing but difficulty in swallowing, esophagitis, that is nothing but inflammation of esophagus, and esophageal symptoms, that is chronic cough, asthma and laryngitis, that is nothing but inflammation of voice box. Next, coming to the important part, that is treatment. So the main goal of GERD is to reduce or eliminate the symptoms, decrease frequency and duration of gastroesophageal reflux, also promote the healing of injured mucosa and prevent the development of complications. We have non-pharmacological actions which includes weight reduction or patient with obese condition, or we call it as overweight patients. We have include protein rich meals in diet, also eat small meals in order to control the blood sugar level as well as for proper digestion. Next, avoid sleeping immediately after meals. Avoid food that has direct irritant effect on esophageal mucosa, that is all the spicy related food. Stop smoking and avoid alcohol. We have the pharmacological management. Under this it is categorized into antacid and antacid alginic acid products. We have PPI, that is proton pump inhibitor, H2 receptor antagonist, mucosal protectant as well as promotility agents. So first one, that is antacid and antacid alginic acid products. We have antacid, that is nothing but it is used to relieve the symptoms such as heartburn or indigestion or maybe due to stomach upset. So antacid, it is nothing but it will immediate the symptomatic relief. Antacid plus alginic acid, it is a protective barrier for esophagus against GERD, that is nothing but gastroesophageal reflux disease. Next we have the drug here, calcium carbonate, that is 500 mg. So the main MOA of this particular category is to neutralize the gastric acid which will increase in pH, thereby the pH activity will reduce. We have ADR for this, that is constipation, basically for calcium and aluminium, as well as diarrhea for magnesium and electrolyte imbalance. Coming to the second category, that is PPI, which stands for proton pump inhibitor. Under this we have the classification of drugs such as rabeprazole 20 mg, lansoprazole 30 mg, omeprazole 40 mg and Pantop, that is pantoprazole 40 mg. So the main MOA of this particular drug is it will inhibit H plus K plus ATPase in gastric parietal cells, thereby the acid secretion will reduced. We have the ADR here. The important one is GI upset followed by headache and vitamin B12 deficiency as well as osteoporosis, that is nothing but inflammation of bone. Third category, we have H2 receptor antagonist, and the drugs classified under this category is cimetidine, that is 300 mg QID, which is 4 times a day, as well as ranitidine, that is 150 mg BID, that is twice a day. So the main MOA of this particular drug is it will block the H2 receptors on gastric parietal cell, therefore the acid secretion will reduce. The ADR for this particular drug is gynecomastia, that is nothing but the feminine characteristics in male. Next we have cytochrome 450 inhibition as well as confusion in elderly patients. Coming to the fourth category, that is mucosal protectant, we have sucralfate, that is 2 gram BID, 2 gram twice a day, as well as misoprostol. So the main MOA for this particular drug is it forms a protective gel-like layer over the ulcers, as well as it will bind to the protein at the ulcer base. So the ADR for this drug is constipation, which might interfere with absorption of other drugs. The fifth category, that is protility agents. It includes metoclopramide as well as bethanechol. So the main MOA for this particular drug is dopamine D2 antagonist, which will increase in LES tone, that is nothing but lower esophageal syndrome, as well as increase in gastric emptying, which will perhaps increase in GI motility. So ADR for this drug is extrapyramidal symptoms, that is tremors or fatigue or tardive dyskinesia. Dyskinesia is nothing but uncontrolled or involuntary muscle action. Next, coming to the important part, that is diagnosis. So this clinical history is sufficient. Clinical history might include the patients with past or present medical features like the chief complaints or the past medical history, the previous allergy and all of that. So clinical history is sufficient to diagnose GERD in patients with typical symptoms. Next, we need to perform the diagnostic test, for example like CT scan, bronchoscopy, colonoscopy or mammography in patients who do not respond to therapy or who present with alarmic symptoms, that is like the emergency symptoms. So endoscopy is preferred for assessing the mucosal injury or other related complications. Next we have ambulatory pH monitoring, as well as we have esophageal manometry. So manometry is nothing but it is a kind of a diagnostic test which is used in GI in order to assess the muscle formation, as well as empirical trial of PPI may be useful. Empirical, it is nothing but it is the initial treatment before the actual final diagnosis is done. We have the pathophysiology, that is the last part. So decrease in gastric emptying, hypersecretion of acid in the stomach or impaired esophageal motility and increase in abdominal pressure. All of this will lead to acidic gastric secretion reflux into the esophagus, as well as gastric enzymes such as pepsin, intestinal enzymes such as trypsin and bile salts, it will enter the esophagus. Once it enters the esophagus, there will be esophageal irritation and erosion, that is washing out of mucosal lining. Once there is irritation in the esophagus, there will be inflammation of esophagus, which is also called as esophagitis. So once there is inflammation in esophagitis, it will ultimately lead to GERD. So the summary of this session is like the definition, it is nothing but it is a chronic reflux of stomach acid, that is HCl, or bile into the esophagus, which will lead to mucosal irritation. Next we have causes, that is it will lead to weak LES, that is lower esophageal syndrome, obesity, pregnancy, chronic cough and delayed gastric emptying. Coming to the symptoms, we have heartburn, dysphagia, as I already mentioned it is difficulty in swallowing, hypersalivation, cough, asthma and laryngitis, that is nothing but inflammation of voice box. Under non-drug measures, we have weight loss, small protein rich meals, avoid post meals, avoid spicy food, avoid smoking and avoid alcohol. Coming to the drugs, we have antacids, that will neutralize the acid secretion. PPI, it will inhibit H plus K plus ATPase. H2 blockers, it will reduce the acid secretion. Sucralfate, it will give the mucosal protection, as well as metoclopramide, it will increase the LES tone and motility. Coming to diagnosis, we have clinical history, endoscopy, pH manometry for atypical cases. So reference I've referred Deperio, that is 12th edition, as well as Roger Walker 6th edition. Thank you.